We're now going to have Dr. John Deveikis. He was formerly at MUSC, an interventional neuroradiologist. He's at the University of Alabama now. And I've asked him, we'll see what he says, but I've asked him not to talk about what you might do in the brain itself. This isn't a primarily interventional neuroradiology conference, but as I alluded to with the esophageal talk, we borrow things from a lot of related fields. So I asked him to tell us some of the things that he gets involved with that we may be able to use to solve all the problems we come up with. Dr. Deveikis?
Thanks, Bain. You know, when you asked me to talk to you folks here, I figured there's nothing I can tell you about bleeding because you're all over bleeding, but hopefully it gives me a free trip to South Carolina. So, you know, basically, let's see, which way? Okay, no disclosures, incidentally. Well, what I thought I would do is just totally deconstruct what I do and kind of explain in a very broad sense what we do and some of the toys that we use, and maybe you can get some benefit from that. Otherwise, this will give you, you know, time to take a little nap or something here. But when we see somebody with bleeding, we basically have a couple of important things that we want to do. One is to control the bleeding, and we want to control it securely, because if you do anything that is very transient, they'll start bleeding again. But, you know, especially in the head and neck, we want to preserve neurological function, and in order to preserve neurological function, we want to understand the anatomy and the physiology. And a very important thing on deciding what tools to use is to decide what size vessel we're dealing with, because different sizes require different tools. So just to illustrate, I'll show a couple of cases and show how we kind of break it down and decide what to do and how to do it. So this is a young teenager that had frequent sore throats and had tonsillar hypertrophy, and so he had a tonsillectomy. And so that was complicated by diffuse bleeding, and that's where we got involved. So the bleeding was packed, and he was taken to the angiography suite. And the important thing is to go back to your anatomy class and try to wipe off the cobwebs and remember what vessels could be involved. Well, so we know that it's in the anterior part of the neck, so it's not the vertebral arteries, so something in the carotid circulation. And unless there's a gross misadventure where the patient might have a medially positioned carotid, most of the time it's in the external carotid circulation. But even there, when we take the pictures, we don't see any obvious bleeding early on, but when we look a little closer later on, there's some funny business going on, and that certainly may be something that's involved. And if we remember our anatomy class, the tonsillar arteries come off the proximal facial artery, and so that would then be what we'd classify as a small vessel. So something, you know, under a few millimeters in diameter is a small vessel, and so we have small systems to deal with it. So we use a 4 French catheter, and that will be used as a diagnostic catheter, but also as a guiding catheter to deliver a very small microcatheter over a very small microwire. We use heparinized saline flush through every port, so the sheath, the guiding catheter, and the microcatheter all have continuous infusions of heparinized saline, and that will be delivered through these rotating hemostatic valves. People also call them TUIs, but you know, us neuro guys don't call them that. But and so it might freak out some people about using heparinized saline in an actively bleeding patient, but not to worry. The important thing is we don't want air bubbles or clots, because anywhere in the head and neck, air bubble or a clot equals a stroke, which equals, a devastated patient and all kinds of problems. So, and the other thing is that all these devices work better when they're bathed in fluid. So that's why we have a continuous infusion. And the thing to remember is that clot is not a very effective hemostatic agent, and that's one of the reasons why these patients are actively bleeding after trauma or whatever, because their own hemostatic process doesn't completely seal off the problem. And the other thing is that the doses of heparin, even though we use 10 units per cc, there's not a lot of systemic heparinization during these procedures. And so with this tonsillar artery bleed, we can catheterize it with a microcatheter, and there you can see the active extravasation, and then there it is again there. And so, then comes the question, what do you use? And there's lots of tools that are out there. Particles are something that you can inject through a microcatheter, but I don't like them in the active bleeding situation because for one thing, they're unpredictable. You can't see the particles. For another thing, it's very imprecise, so they may shower wherever. And they may also clog the microcatheter, and worse, they may reflux and go into some territory you don't want them to go. Gel foam has some of the same problems that particles have, plus it may not be a secure permanent closure. We do tend to use it for treating tumors and things like that, and also we use particles for embolizing bleeding tumors, but an active extravasation, we want to use something different. And a lot of people like coils because they're fairly quick and easy to deliver, but the problem is they tend to occlude proximal to the site of bleeding, and unless you can lay the coil across the bleeding site, it will not control the bleeding, because collateral flow is very rampant in the head and neck, and collateral vessels will keep it bleeding if you just put a coil proximal to the site of bleeding. The ethylene vinyl alcohol, also known as Onyx, could be used, but it is way too slow. And if you've ever been around it, the DMSO in there stinks to high heaven, and patients will smell for several days after the procedure, so tend not to use that. But N-butyl cyanoacrylate, also known as glue or TrueFill glue, is very fast, it's very secure, and it's very predictable. So that tends to be my treatment of choice for actively bleeding small vessels. And so this is the before and the after, so we can precisely seal off that one area and keep blood flow in the facial artery, and it works pretty well for that kind of scenario. So the advantages to NBCA is that you can use very small catheters. It's very definitive embolization because it's a permanent seal, and it's precise and predictable. So that's that. So now once you get to bigger size vessels, you need different tools. So this is a young guy that was shot in the neck, and he had massive oral bleeding, and he was resuscitated, but his pressure was dropping and he was still bleeding. And he, here you can see the tract. It's not a particularly pleasant looking scenario, because it's like running right where you expect the carotid to be, and he had an immediate CTA, which is great because you can get this done within a couple of minutes and have a pretty good idea what's going on. And here you can see there's massive extravasation. So with these larger vessels, we have larger devices. So, except in small kids, we would tend to use a 6 French system. I still use 4 French catheters as a diagnostic catheter, but then we can exchange for a 6 French guiding catheter. So that'll give us a bigger system to work with. And what I like to do when it's massive bleeding from a larger vessel, I like to use balloon occlusion of the proximal vessel, and that will control the bleeding while we're fuddling around with our microcatheters and doing our embolization. So you can either use a double-headed rotating hemostatic valve like this one here and put a microballoon next to a microcatheter, or we can use a large bore balloon guide catheter, which most of the time is larger than 6 French. The smallest balloon guide that we tend to use is a 7 French system. And so in a medium-sized bleed, this is the shrapnel throughout the neck here, and you can see active bleeding from the external carotid. So fortunately, it wasn't the internal carotid looked a little bit wounded here, but it wasn't the source of bleeding, and it was free extravasation from the external carotid. So we could quickly put up our balloon catheter and slow the bleeding, and then with our microcatheter we could see that there's active extravasation. So a small droplet of glue, and then just for good measure laid a couple of coils there. But that's sort of our strategy, to use glue whenever possible, and sometimes supplement it with coils in the medium-sized vessels. And then once you get to large vessels, then things are a little different. So this is a 70-year-old lady with a history of cancer. So already that tells you that she's potentially at risk for having problems with bleeding in the head and neck, and she was treated with radiation therapy and chemotherapy and tracheostomy. So her vessels were sort of wounded by the radiation therapy, and now she's got headaches and intermittently spitting up blood. So on the arteriogram, you could see that she has a what looks like a pseudoaneurysm off the external carotid. So this would then qualify as kind of a medium-sized vessel, and that was treated with coils. And actually, I didn't do this procedure, but my partner embolized that with coils that stopped the bleeding, and she actually did well for a while, but then she returned a couple weeks later with intermittent bleeding, and then at the on the morning, early one morning, she had massive bleeding, and then she was taken to angiography. So in this scenario, we didn't know, is it the external carotid bleeding, or is it the common carotid bleeding, or something worse? And so she had we used a fairly large system, exchanged for a long sheath, which we could then use to deliver stents or whatever. And so she had, on the angiography table, you could hear the bleeding as it was gushing from her mouth. And this was a kind of a oh no situation. And this is the so-called carotid blowout, which is catastrophic sudden bleeding from the carotid in patients that usually have had cancer. And then, just like this patient, they can have sentinel bleeding. And then sometimes the only way you can avoid death is to occlude the carotid, but you have to realize that carries a 15 to 20% stroke risk. And you can see it definitely, sometimes you have to occlude the vessel when it's sort of shredded, just like this tire. But in this case, we did a covered stent, and that worked pretty well. But you gotta realize that there's good news and bad news with these stent grafts. They can rapidly stop bleeding. Sometimes you do have to do a gentle angioplasty to seal off the bleeding there. But you have to be very careful that you don't overdilate, because that'll rupture the vessel, which are already quite weak. It may be the best bad option for patients with limited collaterals, but we do know that long term, some of these people will thrombose the stent grafts. Some of these people will get infected where the tissue breaks down, and they can then, I've seen these stents actually migrate out of the neck, and then they re-bleed, and it's a nightmare. So it's not a perfect solution, but it is sometimes the only option in some people. And then another case with a gunshot wound to the face, massive bleeding. He was taken to the CT, and you could actually see a fountain of blood coming out while he was on the CT table. And so he's taken across the hall to our angiography suite. Again, we use kind of 6 French as our initial setup, but then put a balloon guide catheter proximal to the site of bleeding, and we could see here that the internal carotid was damaged there, and also the external carotid was damaged. So it was damaged all the way across the neck there, and so we had a proximal balloon guide in there, and that's where the injuries were. We could see the distal vessel was supplying a lot of the brain, but we wanted to know, would this patient tolerate occlusion of that vessel? And so we can actually do a balloon test occlusion with a proximal balloon by injecting contrast through the end hole of the balloon and then watching for washout. And what this told us is there was good collateral flow from other territories that could potentially supply that hemisphere. And so since this patient was an extremis and we couldn't do a test occlusion with a clinical test, we did an angiographic test, and then we occluded the carotid, and unfortunately his other vessels kept blood flow to the brain. And so, it's very important to test the collateral circulation and find out if the patient will tolerate it, because without testing, there's a 26% stroke rate, 12% mortality. With test occlusion, we can cut that in half, and so this is something you really got to assess the distal collaterals. And finally, just one case with massive high-speed trauma, and there's a carotid pseudoaneurysm there. Those kind of cases, we can potentially use stent grafts, but the problem is none of the stent grafts are ideal for that situation. These are the stents we use for stent-assisted coiling, but obviously it'll bleed through those struts of the stent. So, covered stents are usually not flexible enough to get in the head. This was a Joe stent, which is flexible enough, but there are all kinds of regulatory issues because it's not approved for use in the head. And then these flow diverters, this is the pipeline device, which can definitely slow the bleeding, but unfortunately it will not stop active bleeding. And so none of these are perfect, but sometimes we have to make do with what we happen to have. And so the take-home points are that we can use stenting or stent grafts to treat large vessel bleeding, but if possible, we want to occlude it as long as there's good collateral flow to the distal territory. And definitely the end organ we want to preserve in these cases. And that is that. Any questions?